facility. So when we have a comprehensive primary health care that is serving the needs of the people, that is giving the best of its services. And then we also have efficient secondary healthcare service that is serving the needs of the people. And we have a functional and well-equipped tertiary healthcare facility. Then we can say, yes, the value chain is working. So each level builds on the other to ensure continuity uh, from the previous. The concept of health and its determinants. We know that WHO defines health as a state of complete physical, mental, and social well-being, and not just the mere absence of disease. We already know that. So if we have that in our mind, we will now see that when we are talking about health, we have to look at all the encompassing parameters that are involved. Now, I want us to know that health for any individual stands on 5 pillars, and these are the pillars that determine the health of any individual. One, we have nutrition, the nutrition of the individual. Two, we have physical activity. Three, we have sleep. Four, we have mental health. Five, we have social connection. I tell you, nutrition goes a very long way in determining how healthy any individual is in any system. In fact, it is always said that an individual is as strong as what he eats. And I believe that the people who treat children, those who handle children can attest to this easily. They can easily tell you that this child is sick, this child is not well because the child has not been taking enough nutrients. And that's why we have all this range of diseases, marasmus, kwashiorkor, and all kinds. Even in adults, we also know that we have adult nutritional diseases and deficiencies. So for physical activity, we know that individuals' physical activities go a long way in determining the level of health that they have. Those who live sedentary life, we understand that sedentary life has a tendency to predispose to many conditions like obesity, with attendant risk of developing diabetes, high blood pressure, heart, coronary heart diseases, and so many other things. So it's quite important. And then sleep. Sleep, as simple as it may look to many individuals, it is already known that those who are unable to have adequate sleep, a sleep of up to 5-6 hours, have been found to have distortion or disturbance of their health. So we can see that those who are working in such a way that for a long time they have only very short sleep, like many people do when they work in 2-3 places, like some of our relations and friends do when they are out of the country or other places. They take in 2-3 work and have just little time to sleep. Or those who work in other industries who decide not to give themselves enough sleep are actually endangering their health. Mental health, we also know, is so crucial, especially in the time we are living in now. We are living in such a time that the stress level in this community is higher than ever before for economic and security reasons. We all know they are all interlinked and interconnected. And it's so crucial that people's mental health take a very good center stage, especially at this time we are living in. Social connection, we all know, social connection is so important in ensuring that individuals have the buffer to stand challenges that may come their way, social challenges. A lot of people will tell you, we've been, studies have shown that the people who have a lot of social linkages uh, tend to survive shocks, societal or issues better than those who live in the solitary life without much social activity. Their coping mechanisms, the coping mechanisms are better developed in those who have robust social connection. It is documented. So, like we said, the health is influenced by all those factors. So, go back. They, when we leave the level of an individual, just like as the five pillars, or we go to the what we call the determinants of health, which are known. Now, these determinants of health, it's just like putting this pillar again, this five pillars in another way, in order to make it clearer for those that will follow, because other authorities have classified these factors in another way. They put it this way. They say they are called the determinants of health, and they are also five incidentally. You have biological, one biological, two social, three economic, four environmental. Yeah, because the some of the factors are actually merged together. So there is nothing much to say on this level because many have, I mean, much have been explained in the five pillars that I mentioned above. But be that as it may, we should know that biological here, we are talking about two factors here: the genetics of the individual as well as the diet of the individual. I think that is the one that has taken the two combined factors. So we know that the health of any individual is first determined by his genetics. That is, genetics is the first foundation for health, as you will all realize. Now, I give you an example. The fact that an animal is born and answers the name of a horse, or another one answers the name of goat, is all from the genetics. And so, for in the same token, any individual that has a sick genetic, that is to say, the person has some genetic conditions. We all know if it is, we know something like sickle cell disease, we know thalassemia, we know all those congenital abnormalities of the bones, and so many other abnormalities that are passed through genetics. We know that those are already a limiting factor as far as health of any individual is concerned. An individual born this way is already limited. And so, diet, we have already mentioned that. Social is like I have said, social is also very important, but economic, which is what I need to emphasize. At the end of the day, the economic status of any individual will go a long way to determine the person's health level. It goes to, It goes all the way to affect everything the individual is doing, from what the person eats, from to where the person stays, to his ability to even take care of, to have access to many other things of life that will make the person live a reasonable, healthy life. And then that actually we all know it cannot be overemphasized. And then the environmental factors. We know environment as a very crucial factor in determining the health of not only individuals, but community. For instance, people who live in slum, you can judge that those who live in slum and who live where there are waste dump sites close by, they will be predisposed to some kind of ailments that are related to the air, the polluted air they breathe, or water that they take that may be polluted or may be contaminated with all kinds of contaminants. And then you can also see that individuals that live in good modern houses with modern facilities in nice environment, you see that automatically have been precluded from some kind of diseases, things like all those diseases that arise from pollution of water and other things. So environmental factors are very, very important. So what are you going to say about the levels of delivery of care in Nigeria? We said the value chain has to be applied to, we have to look at the value chain based on the various levels of healthcare delivery in Nigeria. Otherwise, we may miss the point. Because the primary healthcare, we have to look at it, we have to look at secondary healthcare, we need to look at the tertiary healthcare. And then at every level, what we see its own contribution. Primary healthcare is the cornerstone of the universal health coverage, we all know. And we also know that the universal health coverage means that people should be able to have a level of health care that is safe and that is is what will I say, is safe, is accessible, is they will be able to take care of in terms of their finance and other things. And then nobody should be disadvantaged because of the reason of his social level or class when it comes to this. So it focuses on primary healthcare, focuses on that universal health coverage. Its main activities, we all know that the activities are on prevention, education, immunization, nutrition, sanitation, maternal and child health care. Those are, cornerstones of primary health care. We all know it as the first point of contact in the community. Primary health care centers are all over the place. They are all over Jalingo, in many other places. We all know them. And then the next level is secondary care, secondary healthcare delivery. And I said secondary healthcare offers specialized services of conditions that are beyond the primary healthcare. And we all know that is the most popular that we know. They, uh, they include the general hospitals, the referral hospitals, and so many other private hospitals that offer some of those services. We know the services there will include some surgical services where they can do they can take care of appendix, and they can take care of hernias. They can take care of women who are unable to deliver by themselves, who may have to have cesarean, and so many other activities at that level. So that is the one that is very popular, is very common, is very available, and all the local, I mean, all the state governments.
Hello, ladies and gentlemen. We seem to have a little technical problem. I cannot hear him, and I believe some of you cannot get the audio. So you should be a bit patient. You hold on while we sort out the problem. Thank you.
Can we go back to the primary? Um, Okay. Sorry for the interruption. Uh, we're talking about the various levels of healthcare delivery service, and we just finished talking about the primary healthcare. So we're going to talk about the secondary healthcare. We say the secondary healthcare is the service that is so popular to all of us. Is a service that is considered to be a step ahead of the primary healthcare, where more serious conditions, medical conditions are handled, and where medical doctors, our colleagues, are expected to be present at this level. At this level, uh, even surgeries are done for common conditions, especially taking care of appendix, taking care of hernias, taking care of women who cannot deliver on their own. I mean, the cesarean section, and so many other services that can be rendered at this level. We are very, very familiar with this level, and that is the level, like I was saying, the level that the state governments will always beat their chest on, because they try to provide secondary healthcare facility in almost all the local governments in the state. I gave example. I said we have them in Takum General Hospital. We have them in Warwar, Gembus, in Bamboo. and so many other places. And the referral centers will also serve at this level, like the one we have in Mutumbu and Gashaka and Donga, and so on and so forth. So we also have private hospitals who operate at this level. So it's very, very important. So the next one level we have is the tertiary level, or the tertiary level is considered to be the level of intervention that covers highly specialized activities from specialists. And we know that at this level, the manpower that are seen here, medical manpower that are seen here are of necessity specialists and super specialists who intervene in the various areas of medicine, covering neuro, surgery, oncology, intensive care, and all other services that you may think about. Here at this level, we also have transplant services, transplant for heart, transplant for liver, transplant for kidneys, and even other activities also in terms of diagnostic and laboratory expertise and facilities they have provided at this level. This is the level that covers areas that or medical conditions that are beyond what the secondary level can take care of. I would like to say that in Taraba, we are blessed in Taraba to have the various forms of these tertiary level care centers. We have the Taraba State Specialist Hospital, Jalingo. We have the Federal Medical Center, no, not yet, the Federal Medical Center, Jalingo. We also have the National Orthopedic Hospital, Jalingo. Recently, we also have the Federal University Teaching Hospital, Kari. The interesting thing about the tertiary level is they are called tertiary level. They also have three aspects of services they render. They have the tertiary level medical care, that is the specialist level care, and then they have the research which they conduct and publish their work, and then they also have training for other health professionals. Uh, these are activities you find in those tertiary hospitals. People can come for housemanship, in medicine, in other professional areas. People can come for training to become, medical students and other students to graduate to become doctors, nurses, pharmacists, and other areas, graduate nurses and all that. And then we have an extension of that tertiary care, which we now call the quaternary care. The quaternary care is just usually in well-established centers where a lot of research is done. It has to do with experimental medicine as well as some rare procedures. So now we we have we have now let's talk about building efficiency from policy to patients. Now our topic say building efficiency from policy to patients, and we need to know that efficiency is the ability to achieve results with minimal wastage, according to Crunch 2020. And minimal wastage here means minimal waste of time, minimal waste of resources, material, money, and energy, and all that. And then we want us to know that when you want to talk about efficiency, you need to talk about efficiency across three resources that are found in any organization. And these three resources are usually termed as the three M's. The first M is manpower, and the second M is money, and the third M is material. So in manpower is what is taken in popular parlance now as human resource, and we know that a lot in any organization depends on human resource, human capacity. No organization can grow beyond its human capacity. It is the capacity that the organization has in terms of human resource that can determine the capacity of what they can do. For instance, no matter the kind of equipment we have in a hospital, if we do not have a heart surgeon, nobody will operate on the heart, even though the equipment of heart transplant, heart bypass machine and all that may be available. Nobody can attempt to do any surgery on the heart if there's no heart surgeon. So that is what manpower is capable of doing. So for management, it is very crucial, very important that manpower is considered number one priority. Number one priority. Wherever you are, anywhere in the world, manpower is number one priority. So we need to think of doing what to manpower, giving them continuous capacity building so as to get what we are looking for in health. Number two, money. Money here, we're not just talking about availability of the money, we're talking about financial prudence and transparency in handling the finance of the organization. No matter the money that is pumped into any system, as long as there's no financial prudence and as long as there's no transparency, I also tell you, you will not be able to achieve the desired result. Organizational goals cannot be achieved where there's no financial prudence and transparency. Then we also have materials. Materials here, that's number 3M. Material here means all the things that are non-financial and are non-human resource oriented that are needed to make the work go on. They are called materials, the third M. Here we are thinking of modern facilities, we are thinking of the infrastructure, digital infrastructure, we are thinking of equipment that are required for activities of the specialists in the center and the consumable materials that are also needed and the machines that are needed and all things that will be needed to make the work go on well. So that is very crucial. Then the 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 there are policy in going on with this. We need to understand that there are policy frameworks that guide healthcare in Nigeria, because we are talking about building policy. Building healthcare from policy to patients. Let's know that there are policy frameworks that guide healthcare in Nigeria. The key instruments shaping Nigerian health system, we have what we call National Health Act 2014. We have the National Health Policy 2016. We have the National Health Promotion Policy 2019. We have Nigerian Digital Health Initiative 2019. And we have National Population Policy and Strategic Framework for Community Health 2021. Now, somebody will ask, what are policies and all that? I want us to know that policies are instruments in the hand of organizations and authority that is used to drive the organization. Policy in Nigeria or elsewhere. Policy can be in form of law, it can be in form of legislation, it can be in form of pronouncements, it can be in form of some arrangements, it can be in form of some social provisions to support and all that. And so that is very, very key in understanding how any system can move. Because policy is so crucial in any system you really want to run. In Nigeria, the uh, policies are generally divided into four. Incidentally, they are not here. A policy can have four phases. I think I better quickly mention it as I try to. We're almost coming to an end. A policy can be a regulatory policy. Number one, a policy can be a distributive policy. A policy can be a redistributive policy, and a policy can be constituent policy. There are four kinds of policies. So we need to understand this. We need to understand this so that we will know that when a policy comes up, we will know what the policy is all about. When you are talking about regulatory policy is a policy that regulates the regulatory policy is a policy that regulates human behavior, that regulates behavior of actors. In the health system, it means policies that guide conduct of the health professionals that operate in the health sector. So here you're now going to be thinking of, okay, how many professionals are operating in the health sector? What are those policies that are in place that regulate their behavior and conduct and ethics and all that? So a policy that takes care of that is called a regulatory policy. An example is the kind of policy that comes from the Medical and Data Council of Nigeria. You can call the Pharmaceutical Council and all others. And then the distributive policy. A distributive policy is a policy that says, okay, let's arrange some things to help those that have social inequality. A policy like this social fund where they assist the poor. In Nigeria, there was a time they were saying trader money. In Nigeria, there was a time they were also talking about you win, and so that distributive policy gives some kind of support to special groups because of inequality in the society. And then another policy I say redistributive. A redistributive policy is a policy that says we are taking some of these resources from those that already have too much, and we're giving to those that do not have. And this is arranged very well in taxation. In taxation, those that earn from this level to this level are asked to pay taxation of 20% or more, and those that earn below a particular level are even exempted from taxation. That is a policy we call redistributive policy. There is the fourth policy that is called the constituent policy. This constituent policy is a policy that determines the constitution of a government agency and gives it power to the agency and power to the officials of that agency. This constituent policy says that, look, we need to set up an agency, and this will be the work of the agency. This will be the powers of the agency. This will be the powers of the officials of the agency. It can be an executive agency or whatever agency it will be. Like you have now all these professional bodies and the agencies, they are established on the basis of constituent constituent policies that gives them that power, that gives them that structure and function. I mean, the structure and power that they have. It will determine their governing structure. There will be a chairman, there will be a this, there will be a that secretary, there will be a registrar, there will be, and this and this and this and this will be how they will be regulated. So that is just, I think I need to emphasize that so that we will know what policies. I mentioned those four so that we will know. Now, having said that, I also mentioned those policies that we have in place in Nigeria: the National Health Act 2014, National Health Policy 2016, National Health Promotion Policy 2019, Nigerian Digital Health Initiative 2019, National Policy on Strategic Framework for Community Health 2021. Now, I want us to know that the policy in Nigeria, we are well captured in the Health Act of 2014. In that Health Act of 2014, all the frameworks of operations of all the levels of healthcare that were provided in Nigeria, who will provide the healthcare, at which cost will it be provided, and who will regulate the activities, who will watch over who, and where will the resources come from, and how will the resources come from, and all those ones have been packaged very well in the 2014. However, as time went on, there is what we call emerging issues. Emerging issues are things that were not well captured in the National Health Act that now are now coming up, that need some modification or need some addition or need some adjustment. So as time goes on, things begin to come up. So you now see some additional policies coming up, which we begin to tag them the way you are hearing them now. So there will be a time, there was a time it was COVID-19. So many other things had to come up because of COVID-19. And now we know that we are going AI. With AI now, we need to change our methods of operation. And so we need to go digital, we need to do so many other things. And then we are also trying to get the community need to be engaged properly in the strategies of provision of healthcare for the populace. And so you see now we have the National Policy and Strategic Framework for Community Participation and Community Health. So these are all what we need to know as far as policies are concerned. Now, there are challenges. Now, these challenges are there. The challenges are well known to government, known to organizations that are running the activities of healthcare. The challenges are: one, underfunding; two, weak governance; and three, inequitable distribution of resources. Let me just say a little thing about artificial intelligence. I'm not the one that is supposed to talk on the topic. I know there is somebody that is supposed to talk on this topic after me or so, or wherever, because there's a sub-team already on that. I expect there will be somebody that will do justice to it. So I just want to say that AI has revolutionized the diagnostics, the imaging, and the predictive analytics in the health sector. It has changed so many things as far as medical treatment, diagnosis, intervention, medical interventions are concerned. So that nobody can take it away from them. And then what are the benefits? There is improved accuracy and efficiency in artificial use of AI. What are the challenges? The challenges are that we have data bias, and then there's challenge also to privacy. And then there are some ethical issues that really need to be taken seriously. But we want to also know that physicians must guide AI ethically and ensure that patient-centered care is what we get. Okay. Now, ethics and the physician's role in AI. There are core principles. The core principles are there, and which are just four. In those core principles of the ethics is that there is autonomy, which means respect to patients' decision. Patients have right to decide on their to take decision on something that concerns them as far as their treatment is concerned. And then beneficence, which is number two, which is an act. Whatever we're doing must be in patient's best interest. And then no maleficence. No maleficence means there should be no harm. No harm should be meant for the patients. And then justice will ensure that there is fair play. So we physicians must do what must uphold data privacy, we must have informed consent, and we must ensure equity. And we must ensure that these core principles of this AI ethics are adhered to. So it's very important. We are about to round up. We are finally talking about what? Efficiency in practice from policy to patients. So what do we say? We say efficiency must be what? Must be built at all levels. It must be built at all levels. It's so important that we do that. So whatever whatever we need as far as we are concerned, efficiency is something that, like I said earlier, is something that must be operational in every system, so that there will be no waste of resources. I said that earlier. So we need to now say that efficiency must be built at all levels. Now, at the individual level, people are supposed to do what? Try their best to live a healthy life, guided by the 5 pillars of health. So people are supposed to take responsibility for their health. They are supposed to do it for themselves, and we have been guided here by those 5 pillars I mentioned earlier. And for the government does the big chunk of what is needed to provide a high level or improve healthcare for the populace. Well, government will do what? Government will first of all do what? Provide the infrastructure. Government will provide the hospital. Government will provide the facility. Government will employ the people. Government will provide funds in budgets and so many other things to run the system. And so government has a lot to do. Government cannot renege on their promise or abdicate their responsibility. They will have to do this. And as they do that, they should also know that there are also the other aspects that contribute to good health, like providing clean water generally for the populace. We have water treatment plants and water treatment systems in cities and villages and towns and all that. So that is crucial for health of the people. And then what government should provide a good environment, pollution where wastes and other things that are dumped indiscriminately are cleared. The waste should not be dumped where people are living. Waste should be cleared fast and regularly from where the surrounding where people are living to a real waste dump site, which should be far away from where the people live. It's so important. Government should provide employment opportunity for people and also create enabling environment for people to be self-employed, so that people can live economically viable life for themselves. If people are economically stable, they can take good care of themselves, including access to health care. And then we have institutional responsibility. Here, we're saying that there should be enforcement of quality assurance, especially this will come to the level of the chief executives of those hospitals and centers, the chief executives, the medical directors, the chief medical directors, the medical superintendent, the PMOs. You need to enforce quality assurance to ensure that standard operational practices are adhered to, and you also need to ensure that you raise the bar for your own institution. As a CMD, if you determine that you start doing IVF in your hospital, you will pursue it. If you determine that you will start running MRI, CT scan services in your center, you pursue it. If you decide that you want to start doing transplant surgeries for kidneys and for the heart and for the liver in your center, you can pursue it. And if you decide that people coming to your hospital, we have the highest level of laboratory tests that can be done, gene analysis, karyotyping, all that for issues of disputed paternity and blood tumor marker tests and so many other things. You should be able to set up a system that takes care of that. As a chief executive, you raise the bar. Nobody can raise the bar of any institution, I mean hospital, more than the chief executive. So a chief executive determine that this is what you need to do in order to bring the service to your people. And once you determine that, you pursue it. And I tell you, you're going to do it. But you're not only going to stop there. You are supposed to do what? You should ensure staff motivation. You must work with motivated staff. Staff motivation here, you already know it. You must increase, you must make a robust welfare for your staff. Build houses and even give the houses to them to pay on the owner occupier. It can be done. You get your own systems to get that done through with your own management. That can be done. You can also ask that some kind of monetary inducement be given to people who are working in that place for a particular period of time, or something that you will do that will motivate staff. Staff can go for training. Train them in best places abroad. I have opportunity of also training, getting to Harvard, Massachusetts General Hospital. I had opportunity of getting to Lübeck Teaching Hospital in Germany. All these are opportunities that have motivated me, have kept me also on ground. So you, as a chief executive, you should be able to create opportunities for your staff, not only to be exposed to cutting-edge technology in their area of specialty, but that they can be exposed to cutting-edge technology. They can be exposed to these things out there in the world, where the best places, the best places in the world. Send your staff there. By the time they come back, you also see that they will perform differently. They will also have a different mindset. And above all, you are going to be the chief motivator of your staff. So I put this on the chief executive. You know how you can do it. You know how you can get your board and your governing council or board to support you to do this. And then community, you have to build trust, engagement, and financial responsibility. In this case, we need to know that the community should own whatever system that is in them. The hospital that is built in any community, the community should try to support whatever is going on there, and they should also participate in terms of supporting them in whatever way they can. Some communities, there are places where people in those community will say, I donate this building for this activity. Some will say, I have decided that cancer treatment for children should be on my own account. I set up a fund. This fund will be used to treat just cancer in children. Or some will say, oh, this one will just be used to do IVF for couples that have problem giving birth. Or I want to do this special surgeries, eye surgeries for children of poor people, or so many other things can come up like that. So once we are doing this, I tell you that the efficiency will not just be an issue that we'll be talking. It will be an issue that will be on the table for people to experience. So, in conclusion, I want to say that healthcare is a foundation of national productivity. Efficiency, ethics, and empathy must guide all our reforms and our activities. AI should enhance, not replace compassion. Let us build a Nigerian health system where value flows seamlessly from policy to patients. Thank you very much for listening.
Wow, this is professorial in nature. We are very grateful, sir, for this very, very detailed teaching you've given us. Indeed, you have done justice to the team and the sub-team. Indeed, we are grateful, sir. You know, Prof happens to be my teacher, and we know the stuff he has. So we're grateful. In a few minutes, we are going to open the floor to entertain comments and questions. You know, the team and the sub-team, we are choosing carefully by the NMN national. And it's for a reason. And I believe we have learned a lot. And we have unlearned some things, like I said yesterday. Now, whenever one sits under a tutor, there are many things to be learned and some things to be unlearned, and some myths that we'll have to discard. So thank you, sir. I will leave the floor open for the participants to ask their question. And while we prepare for that, I'll like to entertain the few questions that we have on the chat box. The first one was asked by Dr. Nkwanta. The question goes thus: in view of the poor health indices and poor administrative performance of our healthcare system, what is the role of clinical governance in the healthcare system? I take that question again, sir. In view of the poor health indices and poor administrative performance of our healthcare system, what's the role of clinical governance in the system? And the second question by the same person is that the public healthcare system is overstretched. What's your opinion on the best way to develop the private healthcare system? I think these are the two questions we have on the chat box. The others are comments. So, Prof, you can go on with the answer to the questions. Thank you.
Thank you. Yes, the question is apt. Let me answer the first one. Say there is a poor health indices in the country. Yes, the poor health indices in the country is very clear to all of us. We know it. The average life expectancy of the Nigerian, and the male, the female, and our mortality rate, and child, infant, maternal, all that have been really very poor. Clinical governance, yes, clinical governance can do a lot in the health setting, in the sense that it ensures a kind of what will I say? It ensures a kind of accountability. Accountability here is at all level. Accountability means that people, caregivers give account. They give account of their time. They give account of whatever they are supposed to be doing, and whatever resources that is in their hand to address issues that are on ground. So that is to say, there is a level of responsibility by the clinicians and those other health professionals that work with the clinicians, to do only what they are supposed to do in order to address the problem that is on ground, and also to make the best use of the resources that are available in their hand to ensure that they address those issues. It's a woman who comes in obstructed labor, that cannot have an immediate cesarean section because they will tell you that there's no light, because they will tell you that the parks for surgery are not available. They have to go out and buy some of the materials from town. And then because they will also tell you that, okay, that the people are not able to bring blood, and the people are not also able to do one or two things. Clinical governance takes care of issues like this. A woman should not come being sent from a private place by 12 midnight to a tertiary hospital in Jalingo, specialist or FMC, at 1 a.m. And then the hospital says they don't have parks ready to do surgery. I mean, that is a very big failure. It's a very, very big failure. It's not only in that so many other items and every other thing that is needed along the line, from the generator to the fuel to the electricity to the parks itself, and all that will be required, or the manpower that is supposed to be on call that was not found because network was bad, or the ambulance broke down on the way going to go and pick the doctor who is far away from. All are issues that should have been anticipated. We are not running the health system as the military. You know, military, if they want to go for an operation, assuming they want to go for a rescue operation, they will mimic the situation and create a model for the situation and see how everybody will act. We are supposed to be doing this so that clinical governance is actually supposed to make us do this, so that by the time anybody walks in like that, we are already ready. It is not time for us to say we want to go and check whether generator is there, or whether there is fuel, or whether there is this or there is that or not. Remember, we should all remember that there are even centers where they do not even have electricity, and they still have to encounter this kind of situation. So what are those centers doing? Those centers are resourceful. I work in the general hospital where we were before. We used to do surgeries, and I cannot even remember whether I've ever done surgery more than 3 times or 4 with a generator. I think probably 99% of the surgeries I did there were without generator. So we needed to be resourceful. What I'm saying, if you are responsible as somebody who is in charge of theater with your colleagues, whether you're anesthesia or you're a peri-op, or you're a surgeon, or you're a gynecologist, you must be sure that you raise the standard and you raise the alert, where the system itself must be responsive to such things. We are not even supposed to wait until things get wrong. We're supposed to be checking to see that these things are in place, to see that you, as a chief executive, we are supposed to be going on the round. When we go on the round, we find out, is there any problem? Please, people should feel free. We should give room for our colleagues to feel free to address us, to tell us things that are not okay, that they think we should do something about, instead of putting them in a place where they will be afraid to talk. We should allow our colleagues the freedom to speak freely when things are not okay. If the essence is to make things okay, if things are not okay, we must give ourselves the freedom to say these things that are not okay, with the aim of ensuring that these matters are addressed. So clinical governance is key, and like I say, it's from bottom up and up bottom. So it goes both directions. It's not no exemption in the system. So that is one. And then the primary healthcare system is overstretched. And then you say, in my opinion, what do we do to help the private sectors to also come in? Actually, taking care of the health of the population is not the responsibility of, it's not 100% the responsibility of government. Since it is not 100% the responsibility of government, it means that the private people have to come in. Now they can come in various ways. They can come in partnership at some various levels of services, laboratory services, radiological services, partnership in providing. Sometimes they can even bring some equipment to the hospital for them to make use of. And then sometimes there can be group practice. I think what we lack in Taraba is group practice. Assuming we have a good group practice in Taraba, all resources will be pulled together so that you have a center that if you go in at any time, you can get surgery done, you can get CT done, you can get MRI done, you can get any kind of thing you want to do done. This is how you operate a private group practice. And I tell you, a model that was introduced by one of our CMDs in UCH, but that came after I had left UCH. Professor, forgotten that his name, but I will remember. What he did, he created we call it intramural private practice within the hospital, where the so-called people in the society that they like privacy, they like high-level care and all those ones. He created a system within the system for those VIPs. When you come, at beck and call, the doctor is available, the lab man is available. If you want a doctor to be on your head 24 hours, he will be there. And then you're going to pay special rate for all that. And whoever does intramural, you're put on roster. Whoever does intramural receives his pay based on all the calculations. Anytime you walk in to see a patient, it's documented. It is there's a way you put it in the system so that all their visit to the patient is calculated. So whatever they are paying, the hospital collects so and so percentage, the doctor has so and so percentage, the nurses have so and so percentage, and everybody has something there. So they call that one intramural private practice. And with this, a lot of people will not even bother to go and start opening up a private center anywhere. So anyway, everybody will say doctors are always looking for money. That is the problem of people. But the point is that if people travel from here to Saudi, they travel from here to South Africa and America in order to get healthcare, and you can provide that kind of healthcare right here in Jalingo, right here, even in one of these hospitals, why not? We should be able to convince the system on why we need to do all that. So I think we should start thinking. We should start thinking of these kind of possibilities. It's very, very crucial. So private people, yes, try and do that. But in saying this, I want to say with the note of caution that you do not use government time. You do not use government time to go and be doing your private work. That is unethical. That is unacceptable. So that I need to make a caution to that, so that such arrangement, when it is done, it must be done in a very tidy way, so that all concerned will be safe. Thank you.
Thank you very much, sir, for the elaborate explanation given to the question asked earlier. We are grateful. And unfortunately, some of the comments on the chat box, I don't know what happened. Somebody called me and they got erased. But I can see that of Dr. Amadi Monica. She's saying, well done, sir. And probably the person you were trying to remember his name. I can see a UI product here, writing, helping you out, Professor Ilesami or Professor Alonge.
Professor Alonge, Professor Alonge.
Good.
Professor Alonge.
Okay. So it's a good idea that Prof has sold to us. We have a lot of good hands in Taraba. We can start thinking towards that way to improve the healthcare sector, even in the private aspect of it. So thank you, Prof. I don't know if there are questions. If there's anyone that has another question to ask. So I cannot see any hand raised. But by and large, it has been a very wonderful time with you, Prof.
Thank you.
We've learned a lot, like I said earlier, and we are grateful. NMN Taraba will remain grateful to you for what you have done.
Thank you very much,
So,
and thank you for having me.
You're welcome, sir. We're grateful. So I will invite Dr. Teru. I don't know if he's still here with us, Dr. Teru. That is the CME committee.
Yeah,
So
I'm still around.
Okay, you can go on, sir.
Yeah, I don't know. I think this is no longer a CME team. This is the Physician Week team that is being taken. So even though the CME committee was shouldered to look and source for the speaker, all the same, I want to use this opportunity to thank our resource person and the guest speaker, Professor Rimande Ubandoma, who has agreed, even within a short notice, when I approached him just last week about the team presentation. I was afraid because I say, well, this short time and short notice may be a bit difficult for people to begin to look for resources for the presentation. But as you've aptly captured in the introduction, he is a senior colleague who has always stand in the gap anytime the association and his younger colleagues are in need of his service. So we want to appreciate him in a very special way for agreeing to take this team presentation this morning and for doing justice for the presentation. He has challenged, everybody as part of the Physician Week. Not only the government, he has challenged us individually, challenged us as institution, and challenged, even as communities. And so it is something that I must say has really done justice for the theme of this Physician Week. And I hope maybe some of us that are policymakers, those of us who are leaders in our own ways, those of us who are part of the community and part of the physician who also participate in policy making will take the lesson from the presentation and do the little we can do in our own areas to make sure that policy translates to good care for the patients at the end of the spectrum. So once again, thank you very much, Prof, for the wonderful presentation. For all the participants, those who joined in the presentation, I want to thank you once again for finding time this morning to be part of this presentation. I think the CME committee has probably done their own part for this Physician Week. Once again, thank you everybody for making the presentation since Thursday. Very eventful, very interesting. The discussion, the questions have been coming in. So we appreciate your participation. And we hope that another session of CME will come, possibly from next year again. We thank the leadership of the NMA, who has been supportive in the CME committee and CME activities. Once again, I will not forget to thank our ICT person, Dr. Bright, who has always been so wonderful. Before I will reach him to talk about something, he has already, taken the step ahead of me to actually make sure that things go on smoothly. I cannot take your commitment for granted. Thank you very much. The Vice Chairman, NMA Taraba, Dr. Isaiah, thank you very much. You are so wonderful. When you said the NMA should bring, bachelors should bring their girlfriends, I think your good NMA is an open forum for both married and unmarried. And we appreciate you for the clarification. Thank you once again, everybody. And I said we come to the end of the CME, and we wish that people will stay and continue with the AGM too. Please, let's participate and make sure that the AGM is also very interesting and will bring it to an end. Thank you so much.
Okay, thank you very much, Dr. Teru, for that vote of thanks. And like I said earlier, we will be having our AGM thereafter. And at this point, the CME has officially come to an end. So we are going to go on with our AGM in the next 5 minutes. So do well to hang on, as it promises to be a very interesting moment for all of us again. And don't forget, in the evening, like I told you at the beginning of this program, that we're going to have our dinner and cocktail, and the time is still 4:30. Meanwhile, hang on, in the next 5 minutes, we are going to commence our AGM. And I promise you, we're not going to spend too much of time. We're going to be very brief. This is a very unique AGM. So it's going to be very brief so that we can still go out to attend to some weddings and other commitments we have for the day and reconvene later. Thank you. It's yours in service, Dr. Isaiah Hunato.